health links are interesting, and hopefully, for those of you that don't know what a health link is, after our discussion tonight, please ask us, because I want to make sure people understand what the concept of a health link is. So it's really a partnership of healthcare providers that circle around those people living in the community with the greatest needs. So I think we've done this presentation, we did it in Ingersoll, I guess it was in October, and we talked about health links, and there was a good description about, from Mike McMahon, who's the executive director of CMHA in Oxford. I think people have this assumption that when the patient's in the middle, that all the services are connected and coordinated as they provide care for that patient. And that's not always the case. And those people that have the highest needs within our community, and I'll show you some stats on how much money is spent on a very small percentage of the population, those health links allow those providers to work together to make sure that care that's being provided for the patient is being done in a coordinated fashion. The strategy for health links was rolled out by the Ministry of Health back in November of 2012, I believe it was, in collaboration with the 14 local health integration networks. So hopefully that gives you another view of what health links can do for the patient as they're traveling through the healthcare system. So why would we take this approach? So why would we create a health link? And you're going to hear more about this from Shelley, Heather, and Mary. But it's for those people that are frequently visiting the emergency department or frequently being admitted to hospital, likely not having their health care nor their well-being needs met in a coordinated, sustainable way. When older patients are in hospital, they can lose 1 to 5% of their muscle strength every day. So they have a functional decline as they're in hospital in that acute bed. They have functional decline. How do you get them back being able to live healthy, independently, and safely at home? This is the number that I referred to earlier. 1% of our population consumes 33% of the healthcare resources in the province. This depiction here shows 5% of the population consuming 66% of the healthcare resources. So a significant amount of money is spent on a very small percentage of the population. So health links are focused on that top 5% to determine what are their needs, how do we need to provide care better to them, how do we ensure that we have coordination of care for those people, because there's two outcomes to this. One is a quality indicator, so that person's going to get better care. The second one is financial, is that if we're spending a significant amount of resource on this very small population, how can we service their needs better? So there's two ways of looking at this. Ultimately, it's about care for the patient, but there is also a financial driver in all of this as well. So again, this is what I tried to describe earlier, and this is what Mike McMahon said in our Ingersoll meeting. You picture the patient needs to go to their primary care provider, so they go to their family physician, come back. Then they need to go to their social worker, go back. Then they need to go to the diabetes center. And all these connections are made separately, not in a coordinated approach for the patient. So that it's like someone sitting in a room and having to go into separate rooms to visit each of those areas where they need to get care. In a health link, the patient is at the center, and all those people that are part of that person's care are working together in a care coordination plan. So in this example, you have your CCAC care coordinator working with your PSW, adult day program staff, mental health and addictions, a respirologist, all working together to look at the needs of that patient that's got very high needs, and probably their care is not coordinated as well as it could be within for that particular person. It's being done at the local level because this is that person's care is they're going to be looking for care, whether it's in St. Thomas or Tillsonburg or Aylmer. How do they ensure that circle of care is surrounding the patient in a viable fashion? There's some examples of how this has been used in other jurisdictions. In Quebec, they followed 200 people who worked with their care coordinators to have a coordinated care plan in a 2-year time period. They reported an improved sense of well-being emergency department 72% less. So if they're getting their needs met in their own care path, a care plan, it means that they're not going to the hospital for that care on a regular basis. And of these 200 people, 83% fewer times, they were admitted to hospital 83% fewer times than in the past prior to this coordination. So there's tremendous benefit to working in this approach. You're going to hear more about the structure and governance of this from Mary and from Heather and from Shelley, but the intent is that we have care circling around that patient that requires the need, that has the highest need. So who are some of the partners? This is a list of possible partners that could be part of a health link, ranging from everyone to the family physician, to local hospitals, community support services, the public health unit, long-term care. The list could go on. This could be expanded even further if you have someone dealing with the courts, with the police system. That circle of care can actually be widened to not only address health needs, but also social needs for that person as well. Housing is often a significant constraint in terms of living a high-quality, healthy life in the community. Health links are being established in a number of different communities. This shows what the stage of implementation is for all of those. Here in Perth, it's farthest along, and you're going to hear from Mary from the Here in Perth example. Here in Elgin, they're finalizing the readiness assessment. The lead for the Elgin Health Link was the East Elgin Family Health Team, who are here today at our board meeting. Their board chair, Shirley Bureau, and Executive Director Claudia Meyer-Eckel were presenting to us today as well. So different stages of readiness, but all moving towards having health links created within their geography. And this just shows how a health link will improve health. I've touched on these quite a bit already. Starting up in the left corner, identifying those system barriers. How do we work to mitigate those barriers? Identify those people who are having to use emergency and hospital admissions to manage their health. People shouldn't have to be going to the emergency department or being admitted to hospital to manage their regular health care needs. They can be managed in a more effective fashion by having a coordinated care plan, which is moving down here. And sharing information is really key. There's been a lot of discussion, and Mary, you may touch on this tonight, of sharing information across all these providers, because you have specialist records, you have primary care records, you have community support service records. How do we share that in a comprehensive fashion to make sure that the patient stays at the center?